Hi, my name is Dr. Khadija. I'm one of the doctors from the surgery. Am I speaking to Mr. David?
Yes, you are. Hi, doctor.
Hello. Um, can I just confirm your full name and age, please?
David Harvey, 69 years.
Okay. So I'm ringing you from the surgery this morning, just to catch up on how you're doing and then to discuss your recent bloods. Is that okay?
Yes, that's fine, doctor.
All right. So I can see from your records that you were seen in the surgery 2 weeks ago, and you had an episode of diarrhea, and you were feeling really fatigued. Is that correct?
Yes, that's why I came in. And I did my bloods again, and I'm calling to find out what my blood is, my blood results.
Okay. So before I inform you of your current blood test result, is it okay if I ask some questions?
Sure.
All right, that's okay. So from the last consultation, you were having diarrhea. Are you still having diarrhea or has it stopped?
Oh, it stopped.
Oh, that's good. And then how are you feeling?
I'm still feeling really tired.
Oh, okay. So apart from tiredness, do you have any other symptoms?
Yes, I woke up this morning with some headache and dizziness, and the headache's just not going away.
Okay. Have you tried any medication or anything?
I took some paracetamol today. It's not working.
Okay. So you've tried paracetamol and that's not working.
Yes.
Oh, okay. So what about the dizziness?
It's still there. It goes out calm. Not
Mhm.
as bad as this morning, but still bothers me.
Okay. So is it present all the time, or is there a specific time you have dizziness?
No specific time, doctor. No pattern. It just goes and comes from time to time.
Okay. Are you drinking and eating?
Yes, I am.
Okay. Are you also passing urine?
Yeah, yes, I am.
Okay. Have you got any swelling in your legs or any swelling in the face?
No,
Okay. Have you noticed any blood in your urine?
no, I haven't.
Okay. I've noticed here that you are on an antihypertensive, indapamide. Is that correct? For your blood pressure?
Yes,
Yeah?
yes. Yeah.
Okay. And while you had the diarrhea 2 weeks ago, were you still using your medication?
Yes, I take my medication all the time. I don't miss it. I take it all the time.
Oh, okay. Did anyone tell you you needed to suspend it when you were having the diarrhea?
Oh, I didn't know. I didn't know that, doctor, to be honest.
Okay. All right. That's no problem. Um, so from what you're telling me now, just to summarize, just to be sure that I understand you. So you're having headache and you're also feeling dizzy, and you've also told me that you've continued to use your medication since you've had the diarrhea.
Yes,
Okay, and you've not noticed any blood in your urine, and you don't have any swelling in your legs.
yes, that's correct.
Okay, so can we just go through your recent blood tests, if that's all right?
Sure.
Okay, so your last blood test result, that's to check your kidney function, um, compared to your previous kidney function. I'm afraid your kidney function has dropped further.
Oh, I suppose that's not good news then.
No, it's not good news. Um,
Disappointing. I was expecting it to improve. I've been drinking lots of water.
yeah, yeah. Sometimes it happens that from having an episode of diarrhea and the fact that you have continued to use the indapamide, I suppose is not. I'm not blaming you that you've not stopped the medication, because you've informed me that you were not told that you should have stopped indapamide when you were having the diarrhea. Um, so your repeat blood test results also showed that the kidney function has not returned back to your baseline.
Yeah. So I suppose it's the medication that caused it, and I didn't do well by taking the medication.
No, I don't think so, because you were using your medication because of your high blood pressure, and the last blood pressure that we measured were quite high, and using your medications would control your blood pressure and also improve your kidney function. But because you had an episode of diarrhea, that reduced the blood flow to your kidneys and then further caused an injury, which from what we're seeing has not recovered in the last 2 weeks. But what we could do is to suspend your medications for now, but we'll need to check your blood pressure just to be sure that your blood pressure is controlled. Okay, does that make sense?
Yeah, I was really
Okay.
worried about my blood pressure, doctor, because my father had a stroke, and
Okay.
I really don't want that to happen to me. I really want to make sure it's controlled.
Yeah. So, have you managed to check your blood pressure today?
No, I don't have any device at home.
Okay. Is there any way you could get to the surgery or send someone to the surgery to get you a machine so that we can keep an eye on your blood pressure, or we could book you an appointment to come in to see us face to face?
Oh, anything you advise, doctor, I'm happy to do it.
Okay, we could book you an appointment to come in to see us so we can check your blood pressure. And then I would advise that we suspend the indapamide for now. Okay, and then we'll need to repeat your kidney function in the next 3 months. So when we suspend your indapamide, we'll consider using an alternative antihypertensive, which can control your blood pressure and at the same time will not have an effect on your kidney function.
Ah, oh, it's important that my blood pressure does not become too high, doctor.
Yeah, I understand. And that's why I've suggested that we change your antihypertensives to another medication that can control your blood pressure at the same time will not affect your kidney function.
Sure.
Yeah, we could try we could try a calcium channel blocker, something like amlodipine. Have you tried that medication before?
No, I haven't.
Okay. If you're willing for us to try another medication, we could start another medication to make sure your blood pressure is well controlled while we keep an eye on your kidney function. Is that okay?
Yeah, that's fine.
Okay. Do you have any questions for me?
No, you said I can book me for a BP check, doctor. When would that be?
Okay. We could book you in as soon as possible. So because your blood pressure the last time was 150/92, which is on the high side, could you come in this afternoon? Is it tomorrow now? What time am I using now?
Just assume it's routine clinic, remember, routine
Okay.
morning clinic.
So we could book you into the afternoon appointments and then get your blood pressure checked. But I appreciate that coming into the clinic again might cause some stress, and that can also make your blood pressure elevated at the time we're seeing. But we could also give you a machine to take home so that you can monitor your blood pressure at least twice daily, and then you could send us the reading so we can have a look. Is that okay?
For me, doctor, it's no problem at all. My wife can bring me.
Okay. All right. That's okay.
Yeah.
All right. So we'll be expecting you in the afternoon.
Okay, this afternoon. But when exactly this afternoon, doctor?
What time would be convenient for you?
I can come in around 2 or 3 o'clock if that's all right. Do you have, yeah?
Yeah, I can just have a look and see for you. Just hold on.
Okay,
I
that's
think,
fine.
yeah.
We'll book that in. Yes, I'll come.
Okay. All right. Thank you. See you soon.
Okay.
Bye.
All right. Bye, doctor. Okay. According to your time, you still had 1 minute and 38 seconds left. So you've left time on the table. And it's important that you're maximizing your time. So anyone who is listening, you may be consulting in the normal time of 12 seconds for the exam of 15 minutes, 12 minutes or 15 minutes if you have exam adjustment. It's important that you are maximizing your time. Dr. O, let's start. What do you think about this case and your consultation today?
Okay. I think I probably did not ask loads of questions around the reason for the decline, because I just assumed that the indapamide and the diarrhea were responsible
Okay.
for the
So
decline.
should we start by saying what's this man's diagnosis? Because a decline is not a diagnosis in consultation.
Oh, okay.
You always have to mention a diagnosis. So in this case, what would you say is this man's diagnosis?
I'll say he has acute kidney injury from the recent diarrhea he had.
Recent bloods, yeah.
Yes.
Okay. So yes, CKD is a factor here. There's comorbidities.
Yeah.
But also the other thing is uncontrolled hypertension, which needed to be well elicited in this man. So there's a chance, because look at his last BP was not controlled. He's taking medication. He's coming with dizziness and headaches. So a way to communicate that. So I would like to say, you're right. He needs to come in this afternoon, need to get his blood pressure checked. But why? And this is one thing as IMGs we need to be thinking about, that though you know, yes, this man needs to come in, but you need to demonstrate that explanation to the patient. By so doing so, by explaining why he needs to come in, the examiners will understand your reasoning. So when you just go, I want you to come in so that we can check your blood pressure. The patient will say, okay, but why? Are you checking his blood pressure because this is annual blood pressure check? Or are you checking it because you're worried that the blood pressure is too high and that's what's making him poorly today? So one of the lessons there is make sure that one, you are stating your diagnosis. These are things we will learn over time. You are communicating your diagnosis. You are explaining why this is your diagnosis. So I'll probably have said, I'm a bit concerned that your blood pressure might be high. Your last 2 blood pressures was this, which is above the target level of this. It's important we check your blood pressure today to find what the level is, and then we can talk about medication if your blood pressure is too high. So you can see how I've communicated high blood pressure, uncontrolled, and I linked it to the target, because what if this blood pressure was 130 over something and you've not demonstrated to the examiner that you know what the target of blood pressure is? So
but
there is
sorry, can I ask a question?
yes,
So do I
yeah,
need to mention numbers then, or just
yeah,
saying it's above
yeah.
negatives?
No, you have to. There are certain. Don't be too technical in your consultation, because remember, the examiner is not your patient. The examiner is medically trained, but you need to show that you're able to communicate with a patient on a ground level. So yes, there are some cases you will need to mention some numbers. It's not too complicated. So there is a medical calculator we use to check the chances of you having a stroke, and that has shown yours to be high. We usually want it to be below 10%, but yours is 29%. So yes, you can mention numbers, but you communicate in a way that the patient understands. Okay. So our diagnosis here is uncontrolled hypertension, and also we need to, CKD as well. So this is one of the complex cases we need to manage, because we've seen a lot of new hypertension just coming in, but things have changed, complicated hypertension is coming in. So how do you manage the comorbidities in this case? Right. So one other thing, I won't go into a lot into your clinical management. There is a lot to unpick. Our focus of our learning today is the must have in every consultation. So that's what I am going to focus on. Okay. Always allow your patient give you a golden minute. Even though you've primed the case and you need to demonstrate to use the case and use the doctor's notes, the way you start by summarizing the patient notes, previous history, and everything to the patient is not the appropriate way to use the patient notes.
Okay.
We may do that in real life clinic. Oh, I've been looking through your records. I see you saw my colleague did this, did that, is this. Okay, yeah, so let's continue. But in the exams, you need to show that you're giving that patient the golden minute. So even that practice in real life clinic is not best practice for communication and consultation skill. So one thing you must have is your golden minute in all your consultation. And you have to form your phrases. Common one is, what would you like to talk about today? That's the common formulaic one that everybody's using. So it's important that you form your style, your authentic self in consulting with the patient. Always have your golden minute. I've also talked about always mention a diagnosis and explain why that diagnosis is. And there is a whole tactic, a whole strategy to communicating your diagnosis. But it's important that those two things are in your consultation.
Okay.
Now, here is the list of the must-have in all consultation. You must have your eyes. You must have your PSO. You must ask for mood. You must ask for impact. Then the other bits in your clinical management is patient information leaflet, follow-up, and safety netting. These are the 7 core things that must be in your consultation. Golden minute, we all know, must be there. Diagnosis is all part of communicating SHO level. But that skill, you need to demonstrate, that mastery, you need to demonstrate to the supervisor. To your supervisor, if they're doing a court, or to the examiner in the SCA, is the 7 things in your consultation. If you don't have them, you will struggle to get really good marks in that consultation. Even if you do everything right, you asked all the plenty questions, but you don't ask the patient eyes. You won't get. So what was my idea? Did you ask me what did I think? What was I worried about? Because I eventually gave you and said, oh, doctor, I want my blood pressure to be controlled. I'm worried I'll get a stroke. My father had a stroke. I had to chip that in. What do I want from this consultation, which is expectation? I actually want you to give me blood medication for the headaches. The headache is my main problem. Yeah, I want to know my results, but what I want, doctor, yeah, call for my results, but the headache is really bad. And I gave you that clue that I woke up with a headache this morning. It's really bad. The dizziness goes and comes. So the patient wants to feel better. But if you don't ask these things, you are not having patient-focused care. Because in a way, when you're telling me, oh, it's important we control your blood pressure and give you another medication like amlodipine that can control your blood pressure, but not affect your kidneys, you can relate it to what the patient is feeling. I think if we control your blood pressure, this would mean that your headaches can come down and you don't feel really tired and A, B, and C because of the uncontrolled blood pressure. That's how you give patient-centered care. Well, one of the ways. So all of us, we can prescribe medication, but why prescribe that medication and how can you relate it to what the patient is going through? I don't want to have a stroke because my dad had stroke. You can relate that to, yes, I can see it's important to control your blood pressure. I think we should see you as soon as possible so we can make sure your blood pressure is controlled. And that would reduce the chances of you having a stroke. You did mention that you were worried because of your dad's experience. See how I use that information in my clinical management. So over time, you will learn these things, but you're already in your ST, you gave me your level, which I'm mindful of. I want you to start practicing things early so that in your ST3, you don't struggle. Because if you do it in this manner, which you have done, and then you get to your final ST3, you're not wanting to use 2-3 months to change 3 years of clinical practice. So many people struggle to change those consultation habits because they haven't learned the right thing from the very first time. So with regards to mood, there is a way we learn to ask for mood in every long-term case. And there is a way you ask for mood without using the word mood. When we use the word mood all the time, that's the formulaic part that they are catching us in. Same thing with impact. Patient has had a headache and dizziness all day. What has he done? He took paracetamol, but how has this affected his day to day? That's the impact. You did not ask for PSO, but if you had asked for PSO, sorry?
What's PSO? PSO.
Okay. Before I give you that, I want to give you another homework. I'll dash you question as you dash me question. So I'm very easygoing person, and it will stick when we have moments like this. Okay.
Mm-hmm.
Make it an assignment to study the Cambridge model this week.
Okay.
Make it, if that is all you learn from this, you have the 7 things you must have in your consultation structure. But if you do not study the Cambridge model, you will not go forward in this role play or exams. Because the 7 things I have given you as the must-have are also in your Cambridge model. The Cambridge model is the basic consultation skills. Okay. Your PSO is your psychosocial occupational history. You see why I gave you back the question to go and learn? Because that PSO is SHO knowledge, and they're expecting us to be operating at an advanced level. Okay, so go back and study the Cambridge model and study how to ask that PSO in your consultation structure. Okay. So after the PSO describes the characteristics of this man's life, that's the basic explanation, simple description of this man's life. He's 69. Is he married? Does he have kids? Is he working? Does he live upstairs or downstairs? Was he, does he smoke? Does he do alcohol? Does he take drugs? Many times we think PSO is just drugs, alcohol, and smoking and exercise maybe, but it's more than that. The PSO describes who this man is. Does he drive? What kind of work does he do? All of the things that describes this man's way of life is PSO. But now we now have to ask for impact. Impact is, there's a way we ask for impact without using the word impact. And impact is assessing how the medical condition affects this man's way of life. So many times for us as IMGs, we ask for PSO and we think that has covered impact. And when patient says, oh, this headache is bothering me, oh, I'm so sorry, we move on. We actually think we have communicated empathy. So a misconception is that we communicate and we actually think that it has been heard by the patient or we have actually done it well. But many times for us as IMGs, we don't. And we need to learn these things early so that in that final ST3, we are not struggling. So there is a way to ask for impact, assess how this problem is affecting this patient's life without using the word impact. A formulaic phrase is, how is this affecting your day-to-day life? Formulaic. How is this affecting you? Formulaic. How is this impacting on your health? Formulaic. And if you ask those questions, you think you've asked them, you're not getting the marks for it. So simply asking it and think, but I asked it now. Nah, you will not get the marks for it. So we learn how to ask for impact without using those words or formulaic questions. And then you come to your clinical management, which will then be tailored to the case. Clinical management, you have to think about it as patient agenda. What does the patient want? You have to sort that first before your doctor's agenda. So that extra thing you need to be doing. So if you had asked me, at the right time, I would have said, oh, doctor, I want medication so I feel better. And in your clinical management, you start with what the patient wants, patient agenda. So means that you're going after your diagnosis, explaining that's important, why we need to treat it and, and addressing patient concern. You now need to start with what the patient wants. In this case, would have been the medication. But, you did mention sick day rules in data gathering. You didn't mention it in clinical management. You talked about booking BP, stopping indapamide, doing blood tests in 3 weeks. You talked about before you came. So 1, 2, 3, 4 things you did before you came to patient agenda. I hope you can see how we need to start thinking to make sure we are optimizing our points, getting better marks in the exam. Then the rest of your agenda as a doctor, you have to think about it as, what am I treating now? What am I treating within a short term? What am I treating as long-term condition? If you don't think that way, you will only treat the immediate problem. You don't talk about follow-up. You don't talk about who needs to be involved in the patient's care. You won't talk about continuity of care. So this is why I was asking you, doctor, I'm coming today, right? This afternoon, yes. Then what? Because there were other things that needed to be communicated. When I see you in this afternoon, we check your blood pressure. If your blood pressure is okay, then we may need to do bloods again, whatever it is. No, the bloods was done yesterday, so you don't need to do it again. No, then we talk about your medication, but if your blood pressure is not okay, I'll talk to you about a medication called amlodipine that helps control your blood pressure, but would not affect your kidney. You have to explain your rationale for changing to amlodipine. So it's not enough to just say, I will put you on this medication. Oopsie daisy, off you go. Because the examiners are looking for more than that. This is the difference in real life clinic and the exam. In real life clinic, we tell the patient that immediate thing and they go. Because we know what we're going to do next. But in the exams, the examiner is not in our mind. They want to see your step 2, your step 3, your step 4. If blood pressure is not well controlled with this amlodipine, what will you do? When will you see the patient? So you've given this patient blood test of 3 months. That means after you've seen this patient today, I'm going to assume you won't see this patient again in 3 months' time, until next 3 months. What if his blood pressure is not controlled? Does he still need to repeat kidneys? 3 months is a long time for somebody with CKD when it's not yet stable. So even at 3 months. So there needs to be a evidence-based medicine in how we practice even the simple things like hypertension. And we need to be able to communicate that decision, that evidence-based decision, in a way that you're talking to the patient. So it's conversational, but the examiner understands what you are doing because you are communicating your clinical reasoning and your rationale while you are talking to the patient. There were a whole lot of other things you were meant to do in this case, which I'm not going to pick on. For example, whenever you see a case that leads to target end organ damage, always think about breaking bad news. Breaking bad news is not just about cancer and somebody dying. Breaking bad news is when there is end organ target damage as well. So this man is CKD, which has worsened. What do you need to be doing with this CKD? This is now which you should have done in your clinical management, but I want you to think now about your nice CKS. When you see a CKD in a case like this, anybody can answer. You can put that comment in the chat if you want. What should you be doing in a case like this for that CKD? If you don't know, just say, then we can. If anybody wants to type that in the chat, that would be great as well.
Based
so for
on
me,
EGFR, the difference is more than, I think this is more than 50% already. So you should go to the nephrologist.
Yes, but before we send to nephrologist, what's the test we are meant to be doing?
SCA.
Exactly. So do you see that you know it, but you didn't communicate that, and the examiner is not going to pass you? Because it's only what you verbalize and communicate. That's what your examiner will mark. When I say examiner, that can be me who is sitting here today. That could be your educational supervisor who is doing a court to mark your portfolio and document that your management was in. But that could be the SCA examiner. So when I say examiner, I mean anybody listening to you. You knew a patient needed ACR, but wasn't communicated. So this is why I say they want to know your step 2, your step 3, your step 4, full holistic management of the case. They also want to hear your clinical reasoning. You have to verbalize the things you would do if things don't work well. And holistic management is not just about, what you are doing now. You have to think about what extra things need to be done in this man's life. So for me, I would structure my explanation to say, well, there are 2 things that worries me about your blood today. The first I would like to talk about is your blood pressure. There is a chance that it's high, and then I will hit that blood pressure well. I will talk about the medication. I will talk about the dose. I will talk about any other measurements or any, BP checks, home BP diary. Do you know you can tell this man to go and buy a BP device from the pharmacy? Because he said he didn't have any at home. So I tell my patients, sometimes it costs as low as £40. I think it's a good investment in your health. You can buy the BP device and have at home, so you can always check your blood pressure when you feel poorly. Then this man also needs a BP diary, home BP diary. So there were so many things that you could do in this case that even if you're not able to cover all, you can benchmark some, but you have to mention them. Then the other thing I want to talk about is your kidneys. Your kidney function has dropped, after you've broken it gently to the man. So going forward, there are other things we need to check your kidneys. There is this urine test called the SCA, which checks how well your kidneys is excreting protein. And then you go on to explain SCA to the patient, and based on the results and all, you would like a referral to the nephrologist. Would you be happy to attend? See, you are negotiating that nephrology appointment with the gentleman. Then so remember I said you think about the immediate thing you need to do, BP, short-term thing you need to do, CKD management and all those things because it needs it. Then long-term management in this case, what would that be? Sick day rules. You thought about it, but you didn't mention sick day rules. What else?
And the medications to avoid.
Exactly. Yeah. He's on
for knee pain.
ibuprofen, osteoarthritis, so sick day rules and the NSAID. So in your data gathering, you were also meant to ask him. I see in your records, that's how to use your doctor's notes. I see in your record that you've got osteoarthritis. How is the pain today? Are you still taking ibuprofen? Were you taking it when you were feeling poorly? You are checking and then you are giving him the health education. After you've sought the immediate problem, the short term, now you're talking about those holistic management and the long-term things. So sick day rules, including the ibuprofen, whammy drugs. What else would you have done as part of the holistic care in this man? Where is his statins? Curix. That's one thing. Does he need BP? Yeah, it needs to be on statins. Does he need BP checks? Annual BP review.
The pressure review and CKD.
So as you can see here, he's not on the GP register. I'm sorry, hypertension register. So you may even choose to ask him. So in your data gathering, there is a mnemonic called CFAM. You can ask this gentleman, when was the last time you saw the hypertensive nurse to check your blood pressure? Because this man only came when he was poorly. That's the implication. Came 2 weeks ago when he had bout of diarrhea. Has not come for annual BP review. So how do you communicate those admin tax and practice management things? How do you communicate that to the patient to say, going forward, I'm going to put your name on the hypertension register. You're going to get annual invites to check your blood pressure, A, B, and C. And then you go on to explain what is done in the BP annual review. Does this man need vaccines for long-term care?
Yes, he needs annual flu vaccine.
And what else?
And then every 5 years for pneumococcal.
So he needs his one of pneumococcal. And what else? Look at his age.
69.
Shingles. He's close to the age for shingles. So for me, yes, those long-term vaccines. But for some cases, I look at the age and say, well, I can see you verbalize your rationale because it's not always done. I say, oh, I can see you're 69. When you turn 70, you also get a letter inviting you to come get your shingles vaccine. It's important you're getting your vaccines to prevent you from getting sick. Okay. So you see, that's the long-term care and holistic management we need to be thinking. And depending on your case, what you bring forward in that holistic management will change. Because I would definitely not offer vaccines to a shingles person, vaccine to a younger person, or depending on the case. My holistic management may be a parent who is struggling and I'm saying, go to the parenting hub, speak to early help hub. So whatever you bring will differ depending on your case, looking at the time. Okay. So that's your long-term care. And then when you then go on, so I know, patient information leaflet, what would you give this gentleman today? Patient information leaflet. There's no right or wrong, but you have to pick one and you have to verbalize your reasoning for picking that. So in this case, what would you give?
I think I'll give on I know he already has CKD. He probably would know, but maybe sick day rules.
Sick day rules. Why?
Because I see
this gentleman said
he had this diarrhea and he continued to use
take medication.
Sorry?
Absolutely. He took medication, because the man said, oh, I didn't know, I didn't know. So he was not aware of sick day rules. So whenever you're picking a patient information leaflet, pick something that matters to the case. It's not enough to just say, I'm going to send you information from this website and that website so that you can read. It's not relevant. It has to be something relevant to the patient. And then you demonstrate your reasoning and your active listening by saying, earlier on, you mentioned that you were not aware of the medication to avoid whenever you have watery stools. I would like to send you a patient information leaflet on this so that you can read about it and you know what to do in case. So you see, and then you also need to mention where the information is coming from. Mention the name, name of the website, where information is coming from, what they are meant to learn in it, how they are meant to use that information. So it's not enough to just say, I'm sending you patient information leaflet. From where? To do what? How is it supposed to help me going forward?
Okay.
So that's the patient information. I would pick sick day rules in this case. But yes, I may say, okay, I would also add in other ones on, your kidney functions and hypertension. It's just at your any time you feel, you can always read on them. But that sick day rules will be my main focus of explanation. Then I can pad it up with any extra ones. Follow up. Always have follow up in your cases. So your first follow-up, immediate follow-up, you're seeing this man this afternoon. Learn to communicate more specifically your action plans. There is a way we take ownership of cases by using action words. I would like to see this afternoon. And I can look at the register and have you book in this afternoon. We can send you a text message to let you know the exact time. That's you demonstrating you know how to use AccuX. Do you know what I mean? You know AccuX? Yeah. So what you do in real life clinic, you need to be communicating that to the patient and show the examiner that you know your stuff, because these role plays are meant to simulate what you do in real life. So when you're doing role play, you're preparing for the exams. Don't just do it in abstract. Think, if I was seeing this patient in real life, what will I say? That's what you're meant to be doing in your role play. So that's your follow-up right there. I want to see this afternoon. Because I'm seeing this patient early, I may bring my follow-up early. I want to see this afternoon. Then I will talk about that follow-up. If everything goes okay, I still want you to go for regular BP checks with the healthcare assistant until your blood pressure meets the target, which I explained. And then you can then be on the annual review. So I've talked about different levels of follow-up in long-term cases. So giving this patient 3 months would have been classed as unsafe clinical practice. I hope you understand.
Yeah.
For his bloods, yeah. Then last one, patient safety netting. Must have safety netting in all your cases. What would you give this man as safety net?
So since it's coming in the afternoon, I'll let him know that if the headache worsens or he gets any slurring of his speech or weakness of his limb, he should call 999.
Yeah, so this man came in with, I didn't talk a lot about your data gathering, because as I said, go study on the focus questions to ask for cardiovascular conditions in data gathering, including family history of stroke or hypertension is a must in cardiovascular cases. But you didn't ask red flags in your data gathering, and those red flags are the same thing you can use in your safety net. You don't need to memorize new things. Same red flags you were checking that changes your management now are the same red flags you will use in your safety netting. I know you mentioned that you've got headache. Show active listening. Relate it back to what the patient said. You mentioned that you've got headache and dizziness but if at any time it gets worse, or if you have symptoms of a stroke like weakness to your arms and leg or slowing of your speech or A, B, and C, or if you find that you're unable to get out of the house because you're feeling very unwell, call 999. But if your symptoms worsen and you would like to be seen sooner, call this number, your GP surgery 111. So your safety net needs to be specific. When to call 999, when to call 111, when to call GP surgery. It's not enough to just say, give us a call back or just call this. Yeah. So those are the 7 core things to have in your safety net in your consultation, which we have unpicked. I haven't talked about how to do data gathering in details, including data gathering when patients have long-term conditions using your CFAM questions. But I did mention about breaking bad news. And one thing I noticed you were doing as well is using internal summary. I think you were trying to demonstrate using that before you moved on. But there were, your internal summary was just summarizing what the patient gave you as opening statement. There was no red flags or important things that should be in that internal summary. So that's, the 7 things that must be in your consultation. And I want you to start practicing these things, Dr. O. And hopefully your consultation improves. So we've unpicked some of the things, for your level of training. I know you're not studying consultation skills yet, but I would encourage you to start learning because you're already seeing patients. It's not something you leave to your final ST3 and say, okay, I'm not preparing for exams, so I don't need it. You need it now. The supervisor is doing cuts. They're assessing you on these things already. So you need it now, not just when you are getting to that final ST3. So I hope today's session helps to see what your examiners, whether it's ES panel or supervisor or SC examiner is looking for. And I hope you can start applying these things. Next week.